All right, it's time to start. Before we do so, I just want to remind you that this webinar is funded by a venture fund grant to Radiology Alliance for Health Service Research and Radiology Research Alliance from the AUR Research and Education Foundation. My name is Antonio Westphalen. I'm a radiologist at UCSF, and in the next several minutes, we'll talk about the basics of ROC curve. I am sure many of you heard of it, but I have received a lot of questions about the way this is built, where it comes from, what it means, how we interpret the results. So I hope I'll be able to give you a little bit of the background and some tips on how to read the studies that present results with ROC curves. Before we get to ROC curves, it's important to have a little bit of more basic background information. So when you have a dichotomous test, you're going to have a positive or negative type of result, a yes or no. So an example is presence of fracture on a radiograph. Yes or no, positive or negative. And when you look at the exam and you want to determine the test characteristics, we're going to look at sensitivity and specificity, and I'm sure you all have heard of it. Still, I would like to show you the way I think of it. I almost always create a 2-by-2 table when I see sensitivity and specificity reported, and I created in this particular way. I put disease present and absent in the columns, and I put test positive and test negative as rows. And by doing that in the same way always, now I can always automatically build my numbers. So here is sensitivity. You have disease positive, test positive cell over the total of disease positive. And what does it mean? It's the probability of a positive test if disease is present. Specificity will be similar, but we'll be looking now at the probability of a negative test if disease is absent. So very simple. I'm sure you all have heard of that. So let's look at a different example. Instead of a fracture, let's think of serum PSA for detection of prostate cancer. And if you're not familiar with PSA, the values can range from basically 0 to more than 100 nanograms per ml. And then someone may ask, okay, what is the sensitivity and specificity if the PSA result is 3.5? And then 5 minutes later, another patient may say, what's the sensitivity and specificity of my PSA, which was 22.5? And you can see that those numbers are different, and it's not feasible to calculate the test characteristics for each possible value of PSA. We're going to have 3.5, 3.6, 3.7, and so on. So what can we do? So the solution will be to dichotomize the PSA results. So we can say, for instance, if a PSA is less or equal to 4, we're going to call it negative. And if the PSA is greater than 4 nanograms per ml, we're going to call it positive. So after this brilliant solution, someone will ask you, well, is a PSA of 5 the same as a PSA of 25? Is it fair to bundle those two as the same positive? And the answer is no. Whenever you choose a fixed cut point and you make a continuous value test, a dichotomous test, you're decreasing the value of that test. And we'll take a look into that a little bit more. So to do that, I would like to talk a little bit about likelihood ratio. And in a dichotomous test, we're going to have two of these. We're going to have positive likelihood ratio and negative likelihood ratio. And why do we care about it? Well, we care about it because we use these results to tell us what is the probability of a patient having disease after a result is being positive or negative. So how does the test result change the baseline probability of that patient? So just as an example here, let's say a disease X has a pre-test probability. So in the general population, about 25%, or maybe this was based on previous tests. But that's how we start. This is our baseline. So how does a positive or negative test changes that probability? Let's say a positive test is more than 100, the value of 100. So to get that, so how does the test result change the probability? We'll need to calculate likelihood ratio, positive and negative. So let's go back to our 2x2 table, and let's talk about positive likelihood ratio. So positive likelihood ratio will be the sensitivity divided by 1 minus specificity. So what is that telling you? It's telling you the probability that a person who has disease will have a test positive over the probability of a person without disease will have a test positive. So I'm pretty sure you can predict what negative likelihood ratio will be calculated from, and it's basically 1 minus sensitivity divided by specificity, or the probability of a person who has disease will have a negative test divided by one without the disease having a negative test. So we'll go back to that. Well, how do you calculate this post-test probability? So the first thing you need to do is to convert the pre-test probability to pre-test odds. And we usually don't think in terms of odds, except perhaps when you go to a casino. So if you are a gambler, play poker, some of that, then you may have greater familiarity with odds than most people. We tend to think of probability. So this is the formula. To get to pre-test odds, you're going to take pre-test probability, and you will divide it by 1 minus the pre-test probability. The post-test odds will be the pre-test odds multiplied by the value of the likelihood ratio. And it may be positive or negative depending on the result you got from that test. And then you're going to convert back from odds to probability. And basically what you do is you take post-test odds and you divide by 1 plus post-test odds. So you're going to have a post-test probability. So we can look at an example. So let's assume the pre-test probability of a certain disease is 35%, and you calculated pre-test odds, so the odds would be 0.54. Let's say that this test result was positive and the likelihood, the positive likelihood ratio for that particular case was 18. So your post-test odds will be the pre-test odds multiplied by 18, which will give you 9.72. When you turn it back to probability, you have 0.91. So you went from 0.35 to 0.91. So a 35% probability of having disease to 91% probability of having disease. And now I believe that for most people that will be enough to initiate treatment, for instance. Or if it's a very expensive, aggressive treatment, perhaps that will trigger a more definitive test, although 90% is a very high probability. So likelihood ratio. Let's go back to our patient with suspected X. So pre-test probability, let's say 25%. So how does the result of the test will change that probability? Well, first we need to know if the test was positive or negative. So let's say the result was 150, so it was positive. Anything above 100 we would call positive. So we have a positive result. So we need to calculate positive and negative likelihood ratios. And in order to do that, we'll have to go back to our sensitivity and specificity. So applying the formulas we mentioned before, positive likelihood ratio is sensitivity divided by 1 minus specificity, we get 3.2. And the negative likelihood ratio, applying the formula again, you get 0.27. So remember again, the result was 150, so it was positive. Pre-test probability of 25%, Pre-test odds, 0.33. The likelihood ratio, the positive likelihood ratio was 3.2. The test was positive, so that's the number we'll use. You multiply 0.33 by 3.2, you get 1.06. Your post-test probability is 51%. So you basically double the probability that patient has a disease based on the test of the result of the test you applied. So one question, what would be the post-test probability if the test result was 500 instead of 150? And because we dichotomize the test result, it would still be 51%. 500 is just as positive as 150. So now thinking again, why not dichotomize test results? Let's go back and see the same patient. The pretest probability is 25%. And let's say that instead of using a cutoff of 100 to call it positive, we'll opt for a cutoff of 300. The test result was still the same. It was 150. But now, all of a sudden, instead of being a positive result, this is a negative result. And because we changed the cutoff point, the sensitivity and specificity changed. We calculate likelihood ratios again. But your post-test probability now, instead of being 0.25, drops to 0.17. But remember that using the other cutoff point, it was 51%. So you can see how confusing now changing cutoff points can be and how that can in fact affect management of patients. Now from one you went from a higher probability of having disease, and the other one you went from a lower probability. And just out of curiosity, for a result of 500, your post-test probability goes to 60%. All right, so let's go back to test characteristics. If we have a dichotomous test, you're going to have sensitivity and specificity. If you have a continuous test or a multi-level test, you're going to use ROC curve. So that's where ROC curve comes in. Again, what is a continuous variable? It's a variable that can have a result that goes from minus infinite to positive infinite. So PSA, 3.1, 3.2, 3.11, 3.12, and so on. A multi-level test is one that has increasing categories. So a very hot topic right now is PIRAD score. It goes from 1, 2, 3, 4, and 5. So that's a multi-level test. For these two types of tests, an ROC curve summarizes the test characteristics. Now, if you have a continuous test, it's often best to make it a multi-level test. And then you're going to jump out of your chair and say, well, but doesn't that too result in loss of information? And the answer is yes, it does. The reason we do that is that we are dealing with a range of values, and we can change it based on what is more useful clinically and what is more useful to be understood by clinicians and patients. When you have a very, very broad range of values, you sometimes don't know how to deal with the results. So creating the categories make it more easily manageable, and it may be more meaningful clinically as well. So let's look at a table here, again going back to prostate cancer. We have PSA, patients with prostate cancer, and patients without prostate cancer. So if we look at the PSA values of 0 to 4, and we look at the percent of patients with cancer and without cancer that have that value, we see that most patients, the vast majority of patients without cancer will fall in that range, about 80%. So let's go on with this table, and let's see different categories. So in the range of 4.1 to 10, you're starting to see fewer patients without prostate cancer presenting with that range, but now more patients with prostate cancer presenting with that range. And the same thing happens to the range of 10.1 to 20 or greater than 20. Note that the total in the row is 100%. So we're talking about the percent of patients with prostate cancer that present with that particular range. On the other column, we're talking about the percent of patients without prostate cancer that present with that range. So we're not talking about prevalence of disease. Now we can change that, the column titles, and call the test result percent disease positive and say most normal to most abnormal results. So it's the same thing, it just changed what we're calling it. Then we can create now a histogram. That's the other thing we can do. So these are the same numbers. So within those ranges, the percent of patients with prostate cancer, without prostate cancer, presenting with those results. The next thing we do is we select a cutoff. So let's say the first cutoff will be infinite. Anything within infinite will give us a sensitivity of 0% and 1 minus specificity of 0%. Specificity will be 100%, but we're talking about 1 minus specificity. So anything that is less than infinite will be negative. And we start moving that line to the side, changing the cutoff value. So now we're talking about a cutoff of 20. We're going to have a sensitivity of about 27%, 1 minus specificity of 0.5%. This was all calculated from the numbers I provided before. So a negative result is less than 20. We will do the same thing to cutoff 10 and calculate sensitivity and 1 minus the specificity, to the cutoff of 4, and then a cutoff of 0, which will give us sensitivity of 100% and 1 minus the specificity of 100%. So again, I want to point that the data in the histogram does not reflect the prevalence of disease. And then very obviously we noted that the sensitivity and the specificity that we get depend on the cut point that's chosen to distinguish what is a positive and negative test. So from those results, we can build an ROC table. So these are the sensitivities and 1 minus specificity that we calculated before for the different cutoffs. That's all I did. So infinite, 0 sensitivity, 0 specificity. Now this is an increasing sensitivity to 100% when you get to a cutoff of 0. Same thing on the other column. Now, because the first and last row will be always the same for any test, we can just ignore them, and we'll keep the 3 cutoff points that we applied for the PSA. And we're going to use that to now build our ROC curve. And the way we build it is by serially decreasing or lowering that threshold from most abnormal to most normal. So let's look at the plot here. We're going to have sensitivity and 1 minus specificity from 0 to 100, from 0 to 100. And we do plot now the different cut points. Cutoff of 0 will be always here for any test. Of infinite, I apologize. And the cutoff of 0 will be in the other corner for any test. Now, the points that will vary are the ones that we created for the PSA or for any other test. So the most abnormal to the most normal one, and we will connect the dots. So that's how you build an ROC curve. And I'm pretty sure you all were aware of that. Now, it's important to think of discrimination. So a test that is good discriminating disease positive from disease negative is one that separates the bell-shaped curve. There's little overlap when you have the curves. So little overlap is a good test, and you're going to have a large area under the curve. A test that has poor discrimination has a very large area of overlap and a small area under the ROC curve. Let's move on. So ROC curve is a summary measure of continuous or multi-level tests' ability to discriminate between disease-positive and disease-negative cases. More specifically, more clearly, it tells us the probability that a randomly chosen patient with disease will have a more positive test than a randomly chosen patient without disease. So this is what a statistician has in mind when they think of an ROC curve. And trying to illustrate, let's say we have two populations, patients with disease and patients without disease. You randomly select one from each, but obviously you have no idea which one is which, and you scramble them around. You apply the test to both of them, and you will say, okay, the area under the curve is 80% for that test, so the probability that the test will discriminate the two patients in 80% of the times. And I say likely because a lot of times these results are calculated based on optimized populations and studies that are designed in maybe a single institution, and they may not entirely reflect the community overall. But that's the idea behind an ROC curve. So the probability that will be more positive on the patient with disease than on the patient without. Now, if you have an area under the curve of 50%, that is a straight line, the test is useless. It is not better than a coin toss. And that's what it is here. Straight line is a useless test. Now, a lot of theory is good, but it's good to look also at some results. So this is results of a study one of our residents did here. And we looked at PIRADS-2, which is the scoring system using to evaluate MRI of the prostate. And he found that PIRADS was a good predictor of high-grade prostate cancer. AZ stands for area under the curve. So the area under the curve in this particular case was 70%, and the 95% confidence interval ranged from 63 to 76%, and this is what it looked like. The next thing he did is he compared that same curve, now it's the dashed red line, to another curve that originated from a model that incorporated the same scoring system, but also PSA density. And this new curve had an area under the curve of 75%, and this was the 95% confidence interval. And when you look at the result, you can see that it was significantly higher than the first curve. So this was what people usually do. This is the most common thing that people do with ROC curves. They create 2, 3, 4 ROC curves. They look at the numbers. So what is the area under the curve for each one of those? Then they perform a formal comparison of curves, and they find one that is statistically larger area, and they say that's the best approach. But we can go beyond that. When you look at the two curves here, you can see that there is pretty much overlap in this segment here. Here there's a separation of the curves, and then here, although there's a little bit of separation, it's fairly overlapping. Now, you can create also confidence intervals here to see if they really overlap. But in this one area here is where we find a separation of the curves. And this happens to represent the people that receive the score, or the lesions that receive the score 4. So what the shape of the curves tells us here is that PSA density does help, but it helps pretty much only when you have a lesion of score 4. It didn't really affect score 5 or 3 that much. But when you have a score of 4, looking at the PSA density may help you to better characterize patients. So not only looking at the area of the curve, but the shape of the curve is crucial. Let's look at a different study. This is an older study published in Annals of Emergency Medicine in 2003. What they did here is they looked at the white blood cell count in the cerebrospinal fluid and in the peripheral blood. And they wanted to see how that would predict the presence of bacteremia in febrile infants. So they look at this and they saw that the curve for the spinal fluid was 82%, and then the curve for the peripheral blood was 43%. They said, oh no, spinal fluid much better. And then someone looked more carefully and they said, well, what happens if we flip this curve this way and we see that there is that separation? Now that area seems to be better than the spinal fluid. And indeed, it is. So we have here bacteremia patients, no bacteremia patients. This is peripheral blood white blood count. Go to the likelihood ratio, and you will see that when you have a very low white blood count in the periphery, your likelihood ratio is fairly high, even higher than that when you have a very high white blood cell count. So with this in mind, now they came up with the following conclusion. If your peripheral white blood cell count is less than 5,000, this is very concerning. As it goes up, now you're slightly more reassuring, you're starting to get concerned again. When it's high, it's concerning again. And this result would not have been noticed or described if the person had not paid attention to the shape of the curve and if they had only looked at the numbers of the area under the curve. There's another topic that generates a lot of discussion. What is the optimal cutoff point? And by far, the most common thing we see is the upper left corner. And that's a no-no. Do not do that. Now, it's much better to create intervals, again, clinically or perhaps using the slope of the curve, so things that naturally fall into that curve, or identify a point where the likelihood ratio is 1, which means the test is useless. So if you can find that point, you can then say, okay, anything below this is positive or is negative, anything above this is positive. So let's take a look here at a different study. There are several curves here, and they put all the numbers there, and they compare the area under the curves, which is the most common approach. But let's pay attention to this curve here, the type 4 collagen. And now what are the categories that can be created here? So again, if we look at the slope of the curve, we can see that there is a natural shape to this curve. And we can then create categories rather than choosing one cutoff point. And perhaps these categories now will be much more easily understood and will carry much more information than choosing that single cutoff point. Now the other thing that can be done is to create a slightly different shape. Now because the vertical distribution, so as points go up in the curve, that's when you have the disease. Now you can argue that, okay, this is all flat, so nothing changed here, this is all flat, nothing changed. The only segment that really had disease is this segment. You can potentially bundle this here together. So again, this is no disease, no, 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 one disease, no, 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 one disease, one disease, one disease, one disease, one disease, no, 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 and so on. So because of this particular shape here, you can bundle this in one straight category. Now you simplify this, having a smaller number of categories, smaller number of cut points. So you have a cut point here and a cut point here. You have basically 3 bot categories that can be used clinically, more simple to memorize, maybe more relevant, at least when you look at this particular group of patients. We're not talking about generalizing results at this point. Now, the other option I mentioned was looking at the likelihood ratio. And to calculate, to know which of these points here represents the likelihood ratio of 1, we would have to have the data, and we'd have to go back and calculate. But it's very likely that likelihood ratio 1 falls within this range here. And it could be this guy here, or it could be this one, or it could be this one. And the message here is not that, no, it matters which one it is, but it's not necessarily, no, the left uppermost corner. So if, no, likelihood ratio is 1 is this guy here, everything here will be positive, everything above will be, or below will be negative. So those are the ways to select a cutoff point. Now, we should only consider to dichotomize a continuous test in a situation where all the patients have the same pre-test probability of disease, and when the cost of misclassification is also the same for all patients. And in reality, this is only likely to happen when you have a screening test. So anytime you're dealing with something else, not a screening test, you should probably not dichotomize a continuous test, probably best to create categories. So now this takes us to conclusion. I had 30 minutes to share some thoughts on the ROC curve. I am happy to answer any questions you may have. That's my email address. You can send me an email at any time. And to summarize, we're going to look at sensitivity and 1 minus the specificity from the most abnormal to the most normal result. We will plot these, and we're going to have an area under the curve. The larger the area, the better the test discriminates between disease positive and disease negative cases. We can compare area under the curves, but that should not be the only thing we do. It's crucial to look at the shape of the curve, because that can also provide us with a lot of information on how to use the test results or in whom to apply it. And then the last thing, avoid choosing a cutoff point for a continuous test. It's better to create categories. Thank you very much.